thing. Oh, thanks for whoever remembered to hit the record button. I forget it every time. So, we're not going to have a formal break. We are scheduled for 2 hours. We won't take a formal break. So please make sure you take care of yourself. Obviously, get up as needed, and do what you need to do. We want to really focus on connecting our head and our heart today. So a lot of times in these presentations, you're blasted with a lot of intellectual information. But what we want to do for this series is to make sure we're really thinking about how do we connect on a human and an individual level with all of the complicated material that we're learning in our complicated roles that we're all serving today. And then we would love it if you could change your screen name, so it at least has your name, how you'd like to be addressed. You might choose to add your pronouns there. You might choose to add your role, however you'd like to be identified. And if you're not sure how to do that, one easy way is just to look for your own picture on the screen and put your mouse over it. This is obviously if you're on a computer. And then there's going to be 3 dots. And if you click the 3 dots, a menu will open up and you'll see an option that says rename. And if you click that, a box will open up and you can type whatever you want in there. All right, so with that, I'm going to pass it over to Stephanie.
Hello, everyone, and welcome. Also, Karen, you're a pro at this. Like, you're very natural. You've run a lot of Zoom meetings in the past. So,
A couple.
Yeah. Thank you, everyone, for being here. This is the Criminal Justice section for WPHA. It's a newer section, and Karen and I are co-section chairs. We are working through kind of understanding where public health right now is in its interest in working on criminal justice. Also, the amount of understanding and capacity that's already being brought into that area around public health. So this presentation is going to be in part pretty basic and also offer enough context for us to start to consider how we can engage in public health and work around the incarceration systems and injustices that we have in our state. And before we get to that, I'll jump into what we have for an agenda, and then we'll do a round of introductions for the people that will be presenting today. So our agenda is going to go over 4 key areas of the public health engagement in the criminal justice system, including prevention, pre-incarceration, incarceration itself, and post-incarceration, and how we can be involved in each of those areas and some of the context around those areas in our public health work and how it's impacting our communities. We'll also have a breakout discussion so you can all talk with each other about what you currently are doing and where you would like to grow and engage in this work. And we'll also have some moments of reflection and storytelling along the way to kind of, like Karen said, connect the head and the heart and put a real face on the work that we have ahead of us. So that said, I'm Stephanie Gildenband. I am a community health strategist at Winnebago County Health Department. I'm co-chair of this section, and I'm also on the WPHA board. I am going to hand this off to Carl to introduce himself. And then Carl, if you're able to hand it off to Victoria to introduce herself, that would be great.
Sure can. And my Wi-Fi is agreeing with me for now. So good morning, everybody. My name is Carl Fields. I am Director of Community Engagement for a day shelter called the Hospitality Center in Racine, Wisconsin. We are a day shelter and we operate as a soup kitchen. And so I do a number of different pieces of this kind of work in that field. I'm also a community organizer in social justice and criminal justice in the group EXPO, which is connected to Wisdom. Wisdom is a coalition of churches, congregations, and faith-based groups that do work around social justice. I am a person who believes that social injustice equals criminal justice. And so when we are in a community and live in a society that allows for the criminalizing of homelessness and the criminalizing of being poor, that we move people from one system to another. And in that, we miss an opportunity to really help people. So I just want to put that out there real quick that I come from that particular lane. Happy to be a part of the Zoom with you all and to talk through what some real solutions can be to some of these problems that a lot of us know of. And I am going to hand it off now. Go ahead.
Thanks. This is Victoria Faust. I'm with the University of Wisconsin Population Health Institute. For a while now, we've been collaborating with public health organizations and also with EXPO and its development to try and identify connections between public health and criminal justice, and also to try and support the leadership, the civic leadership of people who've experienced incarceration and justice system involvement. So excited to be here today with y'all. Also want to just acknowledge that a lot of the folks on this call have been parts of this conversation for a while now. So want to just recognize that folks like Jaffa, also who I'm about to introduce, and other folks on this call have been involved in meetings and conversations and convenings over the last and presentations through WPHA, through a variety of different mechanisms. A convening we did on this topic 3 years ago, if we don't count the 2 years that just happened, a year and a half ago. So really appreciate people joining this conversation again as we kick off the WPHA section, which was one of our objectives a couple years ago, if we remember. And so excited to see folks again, and just also want to give a shout out to Jess Wang from UW Population Health Institute too for helping make this all happen today, and a lot of background work. So thank you, Jess. So now I just want to pass it over to Jeff Swain, who has been instrumental in supporting both WPHA in advancing some of this work now as the president, and also in the past 6 years has been a great collaborator for us in really trying to advance this conversation in the state. So thanks, Jeff, for joining us today.
Yeah, thanks, Victoria, and good morning, everyone. As Victoria said, I'm president of the Wisconsin Public Health Association this year, and for those of you who don't know me, I'm a public health physician. I really want to welcome all of you to this session. I was very excited when I checked the registration last night, and there were over 100 people that had registered for this, and we've got close to 50 on the call right now, so that's really amazing. So thank you all for joining us. I'm pretty sure that almost all of you already have a good idea about why the criminal legal system generally and incarceration specifically is so very important to public health. But I feel a little bit like I'm preaching to the choir, but I want to say a few words about why these issues are important to the Wisconsin Public Health Association specifically. Some of you are members of WPHA, but some of you might not know a lot about WPHA. So let me start just with a brief overview. The Wisconsin Public Health Association is Wisconsin's largest statewide organization of public health professionals and advocates. We're the state chapter for the American Public Health Association. We've got more than 500 individual members and more than 100 organizational supporting members. So if you're already a member of WPHA, thank you very much. And if you're not, I hope you might consider joining the organization at some point, but we're happy to have you as part of this criminal justice section regardless, either way. So WPHA's organizational mission is to build a healthier, safer Wisconsin through policy and partnership. So it's really core to our mission that our members take the lead on advancing health equity and racial equity in our policy advocacy and in our core planning strategies. And our criminal justice section is a key part of those efforts. Our newly approved strategic plan for the next 3 years has 3 key priority areas. The first one is diversity, equity, inclusion, and belonging. The second is workforce development, and the third is advocacy. So in short, that means we're striving to advance racial equity and health equity, to support a skilled, diverse, and sustainable public health workforce, and to support policies and system change that makes Wisconsin the healthiest state. If you're not a member of WPHA, you might be surprised at our emphasis on advancing racial equity, even though you're probably all aware of a number of local governments and organizations in Wisconsin that have declared racism as a public health crisis. But if you're not a member, you might not know that WPHA was the very first in the country to make that kind of declaration back in May of 2018. So that was before George Floyd was killed, before Breonna Taylor was killed, but it was certainly not before some of our members had seen more than enough and decided to help WPHA cut to the chase and develop this declaration. And I specifically want to lift up and credit Lillian Payne, along with others, who was one of the key leaders of that effort. And it really launched a national movement around these declarations. But of course, the declaration isn't an end, it's only a beginning. And we've got lots of work to do internally as an organization with our members, become more diverse and inclusive, to strengthen a sense of belonging for everyone working to advance public health goals. And we'd welcome you to help us with that too. But today is as much more about what we can do collectively as it is about what WPHA can do internally. And I know most of you are all too familiar with Wisconsin's awful statistics around mass incarceration generally, and racial disparities in incarceration in Wisconsin specifically, and the overwhelmingly serious adverse impacts that incarceration has on people's health, as well as the health of their children and families and communities, and how those adverse effects also disproportionately across Wisconsin's populations. And although some local Wisconsin communities have lifted up incarceration and other criminal legal issues as public health priorities, others haven't gotten there yet. And so we've got work to do. And even those communities that are prioritizing this as a public health issue are still figuring out how to effectively organize to make needed policy and system change. And that's why the work of the WPHA Criminal Justice Section and the UW Population Health Institute and all of our partners are represented by everyone here today, why that work is so important. It's a wicked problem, and that means we all need all the partners we can get. And so, to put it, straight and say it very bluntly, let me just put these things together. Racism is a public health crisis. And if racism is a public health crisis, then mass incarceration is also a public health crisis. And in fact, in my view, mass incarceration is a public health crisis precisely because racism is a public health crisis. And although mass incarceration disproportionately affects people of color, the fact is that the adverse effects of mass incarceration extend to and include every Wisconsin community. So I want to thank you all of you, for all the work you've been doing already in this area. And I want to thank you for joining us here today. And my thanks specifically to the WPHA Criminal Justice Section and the UW Pop Health Institute for organizing today's meeting. And so now I will turn it over to my friend, Carl Fields.
Thank you, sir. So today, wanted to take a few minutes to talk to you all today about getting grounded in the moment, getting grounded in this virtual space that is, and what it's going to take to do this work. What we'd be asking of you, and in fact encouraging of you, is to share with us your professional knowledge on this matter. You are certainly encouraged to do that. It might not be easy in some of these moments, but we certainly are prompting you all to do so. And a personal knowledge as well. That's one of the things that informs this work across different disciplines. One of the hardest things I've seen in doing this work, in both as a professional in the social justice sector and as a person from a neighborhood that has its problems and its challenges, is that one budget does not dictate what happens in this work, but multiple budgets do, because multiple fields do. There is a cross between public safety and public health and public wellness that we need to get an interesting kind of handle on, that I believe we haven't in the past. What would it look like for us to refer to public safety as public wellness? And what would it look like for those who we look to institute public safety carry a public wellness message? What would that look like for that particular kind of focus to help drive people towards the kind of rehabilitation that we all, I believe, strive to accomplish? There are a lot of different people on this call from, whether it's the WPHA folks, or you're from a particular lane in criminal justice, or, your regional chief, like Mr. Thorson. There are multiple ways that we all have poured into this conversational cup. And I ask that you all be open for the next few minutes, or at least the next hour or so, on how to do this work. You're going to hear some things that you may not agree with. You're going to hear some things that make sense. And you're going to hear some things that also you have the opportunity to pour into. But I ask that you continue to take into account what it takes to do this work on multiple levels, because many of us are in this work because we signed on for it, and some of us are in this work because we've had to endure the effects of some of these policies not playing out well. With that being said, some policies are playing out pretty badly for some neighborhoods, and that is everybody's social determinant of health issue. And so that's part of why I signed on to be here today and be a part of this conversation and be a part of this process, is because we're all in this together, period. Not, one caveat or another, not one particular connection or the other. Like, we're all in this together because we're all paying for this to work well or not. We're all paying for this experiment that we call criminal justice and social justice to work for us or not work for us. But either way, the $80+ billion that is our annual budget, all of us get some sort of resource from that pot of resource. And we either signed on to use that well, or we continue to allow it to be used in a way that it has been. I'm not sure exactly who would disagree with what we're currently doing isn't enough or not, but I am assuming that I'm in safe company in saying that we could be doing this better, and that, a show of hands, if we were actually in the space together, would attest to that. I want to speak to the fact that I do work at a shelter where people are in crisis, and so, my particular role in helping people is that I do deal with, triage like situations on a daily basis. And that, has me partial in a very real way about, where to start in this work and how to start in this work. But wherever you start in this work, I would ask that you do so with dignity and grace and respect of the person that you're helping, or the person in the situation that you're addressing. Because that is the, addressing the behavior piece of it, which is standard issue 101 stuff. There are conversations in criminal justice all the time that aren't about addressing the behavior, but about labeling the person as in good or bad person. And when we allow for those kind of labels to float around in spaces that we work in, then we can allow for there to be justification to mistreat people because they're bad people. We can allow to let pass misgivings that don't play out well for the overall goal of criminal justice and social justice, which is, I believe, less victims. If the conversation were focused on and changed whenever it's not about public wellness and less victims, then I would ask for you to be courageous and allow for that shift to happen in your mind. And if it makes sense for the conversation that you're a part of, introduce it. Because I've been, unfortunately, part of many spaces that the conversation was about retribution only. It was about punishment only. And there was also a default kind of a sentiment that said it doesn't matter how much that costs, or how much the community has to, ripple out and endure that. we need to do that in order to be safe. And those kinds of sentiments, I can assure you, do not produce public safety. And we all want that. I'm pretty sure that, uh, 53206 in Milwaukee, one of the more dangerous, quote unquote, neighborhoods in Madison or Green Bay or Wausau, all want the same things that we want: safer streets, the ability for kids to play uh, on those streets, the ability to have schools that are well funded, and prisons that are either smaller or non-existent. Um, we all want that same thing. And I ask that in the same ways that some other agreements always come about, that when you come to such conversations that you assume positive intent. I ask that you come to these conversations because this session here is one of many. I ask that you come to these conversations assuming that the people across from you uh, want less victims and safer streets and public wellness. Uh, to do that allows for you to hear what's being said a certain way. And if it doesn't resonate with you through those lenses, then you can ask for clarity, ask for clarification. Please do. But I genuinely, as a community organizer, appreciate you coming to be a part of such a conversation because uh, the criminal justice platform and the public health platform, to me, fit together quite nicely. And yet, they have yet to really merge well for us in our communities here in Wisconsin. And I think it's time that we change some of that. And the people on this call, whether you see yourself as that kind of a person or not, you are what we would call in community organizing a power broker. You are a person in a position that has the ability to make a decision that changes lives for the better or for the worse. Your role allows for that to be the case. And that is some of the most powerful stuff and the most humbling stuff um, to carry. I can only imagine how difficult that is because I know it's not easy. Playing multiple roles in my life in my city as well, I get that. But I take comfort in the fact that I'm not doing that alone, and also take comfort in the fact that there are people from neighborhoods and from communities that aren't struggling, whether that be economically or socially or criminally, and yet they're part of this work and they're part of this kind of conversation on principle and part of this conversation because professionally there are tools that exist to get this kind of work done so that safer streets can be accomplished, so that less victims uh, can be accomplished, and that's powerful. So I will end it there for now, so that we can keep the agenda moving smoothly. But I appreciate you all being here today, and I ask that you get ready to hear and learn some things that perhaps perspective wise you hadn't known before. And please comment and share as needed.
Thank you, Carl. And kind of connecting all these pieces together here. We have a lot of partners on this webinar, on this Zoom right now, that are public health. We have a lot that are out in the community that are allies and partners with public health in the work that we're doing. And so our hope here is that today you'll get to see pieces of the work that's being done and the work that's ahead of us that supports how you are already engaged in this work. And if you're new to this, that you'll find some places where you can begin to learn about your own local community, what's going on, and how you can get involved. So our goal here is to highlight 4 key areas of public health work that can be done, and to give you some opportunity in our breakouts to get to know other people that are interested, engaged, and involved in this work. So a little bit of learning and reflection combined with some relationship building. And if we were in person, there would be probably a lot more focus on the relationship building and really exploring how we can apply this work. So we're going to try to do the best we can here, but know that we're also planning some opportunities ahead of us to be in person and to really engage with this work that is big and lofty, and also really exciting because it can be very transformative to our communities. So Jess, could you go to the next slide? I'm going to kick off by starting us out where public health is probably most familiar, talking about prevention. And again, if you're a public health partner or an ally, I think this will help you understand how to meet public health also. So kind of take this from both ends of the work in our community. Okay, next slide. So we talk about social determinants of health and what it is that can impact our health, which kind of helps us focus on what are the upstream root causes of some of the issues that we're trying to impact. And incarceration is no different. We just haven't necessarily looked at incarceration through the lens of social determinants, how we can prevent incarceration, and how we can also build up those protective factors in our communities. I'll also say here with the social determinants of health, including having stable housing, good jobs, transportation, quality education, it's both a prevention factor. So we kind of have these 4 quadrants here, but like that last quadrant will come back around to being the same factors that are needed in our community to reduce recidivism and prevent reincarceration. So this can both prevent incarceration, but will also lead us into being the support that is needed for people upon reentry. Next slide, please. When we look at the social determinants, it's not good enough to just broadly impact the social factors that influence our health. We have to look at the disparities, and it looks like the health equity definition isn't there, but we will just fill that in. So we need to identify the disparities that are in our community and move further upstream to identify what are the policies and systems and processes that make those disparities become inequities in our community. And this is so important in our work overall in public health, and we have a mandate to advance health equity. But what we see in our communities as disparities, thanks Jess, and inequities that we want to impact with health equity is only exacerbated within the carceral system. So what we see in our communities is just even more perpetuated in incarceration. And Karen and Victoria will highlight some of the factors inside the system. But I want to touch on a few things as a prevention level of what we can do in the community to prevent engagement in the legal justice system in the first place. Next slide. So if we only look at how we can maybe improve the legal justice system to make it less unhealthy on the people that are engaged in that system, we're really looking at more of the downstream approach. And we do need to do that. We need to improve quality of programming and access to treatment and mental health. And we need a better reentry system and supports around people as they reenter. But we really do need to look upstream and address some of the factors in our community so that we can prevent incarceration in the first place. So this takes us back to the bar high and working to impact the system internally. Thank you, Karen. And also, so there's links to this in the chat. We just have a fantastic team here. I just want to highlight that also. And if we don't address those inequities that are in our community, that are in our systems, if we don't address racism and the core factors that we're seeing play out in the carceral system, we are just going to be perpetuating the system over and over again. And even if we try to improve the system itself, it's still going to have negative consequences on the health and lives of people in our communities. Next slide. So who is affected? A lot of times we just think about the people that are incarcerated themselves as having poor health outcomes. And really it's people that are incarcerated as in they're in jail and prison. And again, Karen will talk about some of those systems, but also people that are under supervision, which can happen for years and decades after incarceration time is over. People who have been revoked. So again, people that are under supervision and may get revoked back into prison. They may lose their job. They may lose their housing, all because of that, which just goes back to those social determinants. The children of people who have been incarcerated, and this gets to ACEs, ACE scores. And a lot of our public health partners are working on addressing childhood trauma and ACEs and really building up those protective factors. But if we keep focusing on punitive measures and incarceration as the mechanism towards community safety, we're only exacerbating those ACE scores and increasing that childhood trauma. So children of people that are incarcerated are greatly impacted, as are the spouses, families, partners, friends of people that are around the individuals that are incarcerated. And again, think about that whole process. Sometimes that's decades of people's lives that are impacted, and forever after people come back into the community. The harm that is caused by incarceration is lifelong. And lastly, communities at large. So if we're not focusing on true community safety and really like rethinking about what community safety is and reinvesting in our communities so that they are strong, and we're addressing those social determinants like housing, jobs, transportation, and education, we are just throwing resources at a system that's creating unhealthy communities, unhealthy people, and unhealthy families. Next slide. Thank you. So what we're seeing in research that's out there and engagement with public health is making an impact around incarceration is the more we invest, and the more we invest intentionally and in a targeted way in communities that are most impacted and that are most affected by incarceration, we are seeing reduced incarceration rates and healthier outcomes overall. So we know that investing in the protective factors and in the determinants of health not only improves health outcomes, but it is reducing incarceration. So this is where prevention and public health really can meet. And we would love for all health departments to name incarceration as a priority and an issue that we are working on. You can also do this by already building this into your existing scopes of work. So if you're working on housing or transportation or jobs or affordable childcare, a lot of the stuff that's coming out of COVID, bringing a lens of incarceration and really reflecting on how is incarceration impacting your community? How is the work that you're doing in your health department or in your other public health places, the nonprofits and even the academic fields? How can you fold incarceration and the work and impact of incarceration into your existing work and name it, identify it, and again, address people most impacted by incarceration in your communities and in your work? The next slide, please. So some ways that you can engage in prevention in the field of working on incarceration is, first of all, naming and addressing racism and oppressive norms in our community. Incarceration is not just in urban areas, it's not just in prisons, it's in our jails, and it's all across the whole state of Wisconsin. So every county has racial disparities when it comes to touch points with the legal justice system. And if we don't name it, if we don't identify it, we can't begin to address it. We can also provide access to resources that communities need. So this is where public health policies and work can really drive the impacts of those social determinants. So good quality education, jobs, stable housing. Increasing access to healthcare. We know that a lot of causes of incarceration are connected to mental health and substance use. So when we say healthcare, it also means access to mental health and substance use treatment services. And while a lot of people, I work on substance use myself, we have overdose fatality reviews. We have a lot of these systems and processes to identify how can we change ourselves to be a better, healthier community. And we see that there's touch points in the legal justice system where treatment and other mental health services can be offered and even mandated. What if we got the services to people before they ever had to have interactions with the legal justice system? So really looking at prevention as a key point in this, and not just that you can use the legal justice system as a way to force treatment and mental health services. Another point is to build out coalitions and collaborations so that community organizations can better support people that are formerly incarcerated and help some of those families that have been impacted by incarceration. So really kind of bringing some wraparound work can prevent future incarceration and recidivism. And lastly on here, improving some navigation to assist with having some of those core pieces of those social determinants. So how can people access housing? How can people access transportation? I think there's a big assumption out there that the services are available if only people wanted them. And really it's cumbersome and complicated. So improving and ensuring navigation support is also a key factor here. The next slide, please, Jess. So what exactly can public health do? We can better understand how our work is connected to incarceration. So if you're not ready to take on incarceration as a core issue in and of its own, learn about how incarceration is playing out in your community and connect it to the work that you are involved in. The other piece is to commit to community engagement and kind of rethinking what community engagement can look like. So we often partner with community agencies and organizations, but really hearing from people that are affected by incarceration and building out your community engagement with people that have been involved in the criminal justice system, by families who are touched by this, and building out trust and having authentic relationship to identify what you can do to prevent incarceration, but also support people as well. The other is to target upstream work to address disparities that are caused by gaps in our system and disinvestments in our communities and inequities that we're seeing. And I specifically use the word target because, again, blanket approaches are not working for the people that are most impacted, and especially for people that are getting into having those touch points with the legal justice system. So who's most impacted and how can you do work to bring housing, transportation, jobs, childcare to those individuals, not just broadly across your community. And lastly, this is the work that I think we want to also really focus on as a section, but how do we reimagine or redefine what community safety is? So it's not just purely focused on the legal issues around safety, but like what does safety mean and what does public safety mean from a social determinants perspective? What does it mean if we truly address racism? And what does it mean if we consider other forms of violence that are being done to people in our community? So reevaluating and redefining what community safety is. Next. So this is a quote that I pulled and a really great article that's linked here, but it really points out that we have to think about what happens before people are locked up. So what's going on in our communities that is causing incarceration? How do we impact that? What are the disparities? How do we most impact the people that are affected? And then we can also work on the issues that are related to incarceration and confinement. But we can't just only work on changing the system. We're trying to prevent people from being incarcerated in the first place. Next slide. And this is, I think, my last one. And this is a transition between prevention and what it can look like to start to work on systems that are involved with the legal justice system. So we can choose to bring more investments around education, having quality education, and our communities also can decide to increase law enforcement in our schools. That's a decision that gets made in our community of where we invest those resources. We can choose to support families and have services in our communities. And we could also choose to have more punitive measures around truancy and having juvenile records that people bear for the rest of their lives. We can choose to invest in our community and have resources, or we can choose to increase fines and fees for homelessness and issues around transportation and housing. We can choose to invest in affordable housing, or we can choose to not and have more evictions and eviction records. Those are records that you can look up on CCAP. We can choose to improve access to substance use and treatment, or we can increase more punitive laws around drug and mental health issues. We can choose to have mental health support, or we can heighten law enforcement in responding to mental health crisis. These are choices, these are policies, these are systems and processes that we all have in our community. And this isn't a definitive list here. These are just some examples of ways public health can find themselves getting involved in our community and highlighting health issues, health outcomes, and social determinants, and how that intersects with the legal justice system. So from here, I'm going to hand it over to Karen to dive into pre-incarceration and touch points in that area.
Yeah, thanks so much, Stephanie, for really just laying out all of the important things that come before the institutions that we're talking about. So I'm going to just run through some considerations to think of once people get into our criminal legal system before they enter in an institution. Next slide, please. So I want to just zoom out for a second and take a closer look at, That's funny. I never thought about that. But just so that we can get a good overview of what our complicated system looks like. In my work in this area, I started as a community advocate, and then now I'm working in nonprofit in the area. But previous years, I was in biological science and biotech. And one of the things that's important in that world is, we're talking about laws there, we're talking about laws here, laws of thermodynamics, which talk about we have as much energy as we're going to have, and energy just gets moved around. It doesn't get eliminated, it doesn't get created. And the reason why I bring that up is because anytime we change one part of the system, it enacts an energy on another part of the system. So when we exist in silos in the roles that we're in, we work to make, the things that are happening in our individual role as good as possible. But if we want a very effective entire system, we really need to focus on what, if I make a change on my end, how does that impact someone else, right? How does that impact another area of the system? So that's just a complicated way of saying it's really important to have a good overview in your mind as you go through about, what other parts of the system are also affecting the work that you do, which is not necessarily in your control. So to make change, in short, we need to be collaborative. So Stephanie was really talking about these community conditions up in the top left here. But as we move through the system in this pre-incarceration period, we have crime that happens, which may or may not be known to police. If it's detected by police have discretion in how they act here. Either there's an informal talking to in the community, maybe no records made, we don't have any evidence of what's happening there. There could be an informal record, so a warning or something that happens there. The next step is arrest, whether that's taking someone physically into custody or detaining them and giving them a ticket or an ordinance violation happens here. And police have a lot of discretion to decide, of course, based on statute, where they want to take the interaction with that individual. We then move from, if they're taken into custody or given a ticket, into the court process. So what is the person's options here for pleading guilty, for having a jury trial, or are they simply not charged by the DA at this point and they move out of the system? If they move through the system, they are found guilty or they plead guilty, we're going to move into a sentencing phase in the courts. So we're moving through police, sheriff's office, potentially jail, and now the court system. And if this happens, a sentence is determined, but they could also be found not guilty. A case could be dismissed, or it could be reduced to just a fine. If they are found to need to serve some time or found to serve probation, might go to jail, they might be under community supervision here, or they might go to prison. So these are the three opportunities here. And then once we move into the jail, that still stays under our county sheriff offices. If we're on probation or in prison, we're moving into a state supervised area. So there's a lot of different levels of government that we're walking through here, with a lot of different practices, different methods of collecting data. And it's important, and I know many counties are working on this, but it's really important that we continue to work to be able to share our data across the system so that we can keep track of things. We can better plan our prisons and jails if we know how people are moving through the system. And that said, we can better plan for our prevention opportunities and our pretrial actions if we know how things are operating once people are out of the system as well. So it's a big push and pull. Next slide. One thing that Dane County has been working on, and I know many others have as well, is taking a look at this pretrial phase. So pretrial, according to Prison Policy Institute, is the fastest growing part of our jail system across the state. So it's important to take a look and ask several questions. As I mentioned, the first part of this, police respond to an incident. In this case, asking yourself, who's arrested and why? How are those decisions made? And are there racial disparities that occur at this point? There are, but how does that happen? How are those decisions made? And then how does a person move through this system? Once they go to arrest and to booking, what does that process look like? Who is released and who is detained at these points? And how long do they wait before they're actually released from jail? And this could either be the time limits on initial appearance, where if someone is being taken into custody and that's their only case, we have a very strict limit. But if someone is on probation or parole and is brought into custody, they'll usually be put on a PO hold, which then buys a little time in many cases to have to bring the charges under those time limits because there's something else holding that person in detention. So looking closely at that process. Moving forward to initial appearance, who's charged? What kind of violations are they charged with? What are we seeing most frequently? And then moving on to whether there's a trial or a plea bargain or the next steps in the system. So if we take a close look at what's happening here, we can find a lot of the places that Stephanie was referring to where we can really work on getting people plugged in to services, to supports, and being able to exit this part of the process so they're not staying within the complicated system. Next slide. Now, one thing that we have available to us are treatment courts, and treatment alternatives and diversions are something that have been talked about in Wisconsin for many, many years. And we've grown somewhat since, the first TAD funding came through in the early 2010s with about $1 million in funding that was spread across about 7 counties. Now, over the years, we're now up to about $7 million of state funding, and we've grown quite a bit the number of counties who are able to provide some kind of treatment court or diversion court. And many counties are also funding their own types of treatment courts and managing that themselves. But if we're looking for ways to keep people out of incarceration, which, our data shows that the less we can incarcerate certain people, the better off they do in becoming, just kind of getting back into life and participating in society. But the treatment courts are one option, and there's many different kinds that exist. One is just adult treatment for drug addiction. We also have in many counties diversion courts, which might look at people who are experiencing their first offense or people who are very young that we think that we can move out of this kind of a cycle to get on their feet. We also have OWI courts in many counties in the state. As we all know, this is a very big issue. These are post-conviction courts, but they're designed to keep people from getting more OWIs and just staying caught up in that system. We have hybrids that are not just looking at addiction, for example, but are also looking at meeting multiple needs. And then we also have tribal healing to wellness courts in certain parts of our states. And then there's the TAD statutes are pretty specific. So there are a few areas that aren't recommended for TAD funding, and that includes mental health courts in the cases where there's not a co-occurring substance use issue. We also have veterans courts. Now, in this case, There are often complications with the exclusion in our TAD funding for offenses that involve violence or are perceived to involve violence. And then we have family dependency, which aren't necessarily meant to provide treatment, but who are really there to keep families together. So we're looking at this in a variety of ways all across our state, and there's a lot of innovative practices coming around. So if we want to really look at pretrial diversion and treatment to keep people out of incarceration, let's work on meeting each other across the state. And we've recently, in the past few years, as a state, worked hard on developing standards for our treatment courts that can be applied. So we have some level of consistency in all of this. And in the list of people that work on this, I noticed that there are some public health folks, there are a lot of criminal legal system folks, but I don't see very much representation from people with lived experience who have actually participated in these processes, or from community organizations that work on the ground with people who are going through this and are providing wraparound services to keep people doing well in the community. So that's one area of improvement that I think we can add to contribute to this area of health. Next slide. So now we'll move into talking about what happens once people are actually incarcerated. Next slide. And for that, I want to go back to our diagram of social determinants of health. So when we think about people being in jails and prisons, that's often where that thought ends. It can be challenging to think about how we connect public health, which is on the outside, to people who are incarcerated inside those walls. And sometimes a lot of our efforts are only dealing with before people go in or after people go in. But there's a lot of opportunity to be able to be setting up supports, to be developing our treatment programs, and to be working on family connections and consistency while people are actually incarcerated. And there's a few things that I want to highlight here. So incarceration is something that has somewhat recently been added to being considered in social determinants of health and kind of falls under this social and community connections area. And it's not just incarceration that we have to think of. As Joff mentioned at the beginning, we have extreme racial disparities in our state's jails and prisons. And we were recently highlighted in a sentencing project report that once again puts us at the very top of the list in incarcerating Black men in the state. We've held this title for a very long time, whether we've been number one or in the top 5, but this is something that we haven't been able to change, and it is really time that we figure out how to do so. So we cannot separate discrimination and equity from incarceration and criminal justice. The other big point here is social cohesion. So how do we integrate with our communities? How do we interact with one another? There's 2 things here. One is the stigma of incarceration that is placed not only on people who are incarcerated, but also their families and their loved ones. And how are they able to connect with others and move through their community, knowing that this is going on? So just keep those 3 things in mind when you're thinking about social determinants of health and incarceration. Next slide. So I'm just going to run through some quick facts and talk about how these things relate to public health, because we talk about racial injustice in our system, we talk about treatment needs, but we don't necessarily connect that back to the full system. So be thinking in your role, if you're not directly involved in jails or prisons, be thinking about where your specific role might interact in some of these ways. This is just a quick overview. These are a couple years old, but they're pretty much the same, showing our racial disparities. On the left here, it represents men in our prisons with 42% Black and 53% white. The green is our women's prisons with about 70% white and 23% Black. Now, remember that across Wisconsin, we're only looking at about 6% Black people in the entire state. So both of these are very large disparities. We definitely disproportionately incarcerate Black people. Not only that, we arrest Black people more often. They go to prison more often and are given longer sentences. That's data that we know. One complicated point in looking at our data here is Hispanic or Latinx population. So the way a lot of government agencies report this is we collect race in one category and ethnicity in the other. And this is the same here. So we know that there's about 10% and 6%, closer to 10 for men and closer to 6% for women. But we don't know where these numbers are intersecting with other races. So that's a really important data category if we want to be talking about the real picture for Hispanic Latinx community members. We really need to take a different look at how we're collecting data there. So keep that in mind as you move through. Next slide. Can we get the next slide? Or are we frozen?
I think Jess might be frozen.
Okay. Let's see. Oh, there you go. And did you want to reshare, Jess, or do you want me to?
I'm happy to. Sorry,
Oh, no worries.
folks. Internet is just crashing.
The good old technology that we all
We
deal
love
with.
it.
All right. So I just want to make the point that every single one of our prisons in the state is operating beyond its design capacity. So our prisons are overcrowded in every aspect. This has been something that's been going on for quite a while, really, since the 90s when we saw a boom in our incarceration rates. Our jails, some are very crowded and some aren't. So when we look at numbers overall in the state, we're looking at about 20,000 people in our prisons and about 14,000 people in our jail. But when we look in terms of public health and thinking about mental wellness and thinking about, your average cold or just, staying well, the more crowded, the more packed we are together, the more difficult that is. And that pertains not only to people who are residents in prisons, but also to people who are staffing prisons, who are working in high stress environments and usually understaffed in a very, very crowded environment. Next slide. And then if you can click one more time there. So this is a little bit old, but I just bring it up to make the point that our healthcare costs for substance use, mental health, but also physical health care have increased dramatically over the last 30 years. In Wisconsin, the medical cost is about $7,000 per person per year. And our healthcare costs are about a fifth of our corrections budget. And so we owe it to ourselves to focus on how we can help keep people healthier while they're inside so that we can help, spend our money in ways that are really making a difference. Next slide. Some of the main drivers here, I'm going to just kind of go over some of the main drivers of healthcare costs and considerations. We have an aging prison population because we have longer sentences because of recidivism over the years. We are now seeing across the country a big increase in the number of people in prison who are over 50 years old. And, we know that there are a lot of health conditions that have earlier onset for people who are in prison because of the stress, because of other lifestyle factors that might come into play. So prisons are having to deal with building geriatric units, dealing with Alzheimer's and dementia and other factors that we didn't have to deal with before. On average, it costs about $45,000 to incarcerate someone in the general population, and it's almost double that for people who are over 50 due to the increased need. Next slide. We don't focus a lot in general conversation about general healthcare needs and chronic conditions. We often talk about mental health and substance use. We often talk about infectious disease for obvious reasons, but we don't talk about what's happening with things like diabetes, cancer, heart disease, and other conditions. Keeping track of what's happening here and keeping people healthy, we know that people have very limited healthy diet options when they're in prison. People have very limited exercise options when they're in jails for longer periods of time. And so how can we adjust these factors so that people are, pushing off these chronic health conditions, not having earlier onset diabetes, weight gain and diet that might contribute to heart disease? These are potentially some easier places that we could focus on to make sure that people's health while incarcerated stays in a good condition, so that when they get out, they feel good enough to go about the rest of their lives. Next slide. Prescription drug costs are very expensive. Now, this is an older slide. This is from 2017, and this is no doubt reduced since then, but this demonstrates, the blue here is the amount of money that we're paying to treat people for hepatitis C. So one of the amazing things that Wisconsin did in prisons is treat everyone for hepatitis C with the cutting edge drugs that essentially eliminate the virus. And when these first came around, they were extremely expensive. The cost is starting to drop a bit, but all in all, prescription drugs end up being about 20% of our health services expenses. 2017, that was about $38 million. So that's another area to take a look at. It's good that we have drugs that people need, but just something to keep an eye on that probably won't change very much in the next few years. Next slide. So then, of course, what we talk about often is mental health and substance use. 41% of men in our prisons have a mental health condition. 7% of those are serious. And it's sort of the general understanding that this is probably underdiagnosed. Not everyone is getting a psych eval when they're in prison. Due to understaffing and other factors, our psychiatrists and psychologists are busy dealing with crisis situations and serious conditions. What does that mean for those who may have, generalized anxiety or depression that hasn't quite gotten to the severe level? How are we making sure that these don't progress beyond what they currently are? For women in our prisons, it's much higher. 90% of women are known to have a mental health condition, 37% serious. And then about 70% of people in our prisons have an identified substance use treatment need, which I believe might be lower than actual. Next slide. Due to budget cuts over the past several decades, really wrapped into that tough on crime conversation, we have very long waiting lists for our programs. So even though we have some great programs in our prisons, and even though we know that we have a very large number of people who need treatment, our waiting list this was at 2018. These numbers haven't changed much over the years, but our waiting list in 2018 was 11,000 people waiting for treatment for their substance use disorder. And then also 12,000 waiting for cognitive behavioral therapy. And we know that there are many, many people who have an identified treatment need before they go into prison who do not get that treatment while they're in prison, either due to long waiting lists or different circumstances moving between buildings or other health issues that come into play. So people might sit for years in prison without really getting the treatment that they need that played a role in getting them in prison in the first place. So in terms of public health, remembering that the people who are in prison, most of them are getting out. How do we make sure they stay as healthy as possible inside? Next slide, please. And then this is just a quick look at our recidivism rates in Wisconsin. And Wisconsin is now looking at recidivism in 3 different aspects. One is rearrest. So this is after you've been incarcerated, if you're arrested for a new criminal offense. Reconviction means that you are actually convicted of that offense. And reincarceration means that that your probation or parole or extended supervision is revoked. And this could either be just plain old revocation with a new sentence, or just a new sentence. And, we're pretty much on par with the rest of the country, looking at recidivism rates, somewhere around 60%, depending on, how we look at this data. And so the factors that Stephanie mentioned are relevant, even though those are good prevention factors. once people get back out, how do we prevent them from going back in? And Victoria is going to talk next a little bit about what that looks like on the post-incarceration side. But just all of the factors that I mentioned previously, how can we do a better job of looking at those things inside so that when a person gets out, they land strongly on their feet in good health, and which we know will reduce our recidivism rates. And next slide. And then just taking you back to our diagram of social determinants of health and all of the things that incarceration impacts, like economic stability, like the ability to get housing in the neighborhood that someone's working in, the ability to get education or get higher education. These are three big factors that are strongly impacted by incarceration that also contribute to a person's likelihood of success once they're released. And with that, I will pass it over to Victoria.
Thanks, I will get myself unmuted. Thanks, Karen. So shifting back around now to thinking about our reentry processes will sound a bit like where we started with thinking about what kinds of systems and structures around the social determinants are important to think about what helps everyone be healthy and successful in our community. So if we think about the goal of the concept of reentry, if you will, is for people to lead law-abiding lives, support dependents, pay taxes, engage in pro-social activities, and be positive and contributing members of communities. So it's interesting to think about what types of things support that, and then what types of places people are coming from that that Karen was just describing that have also created barriers to that happening. So for the sake of what we're talking about today, reentry also involves both leaving institutional living situations and all the dynamics that come with that, and also the concept of supervision that we have in Wisconsin too. So supervision includes parole and probation, and it has also in some places been seen as a method to help reduce numbers of people incarcerated, particularly in light of the costs of incarceration. But also it comes with its own costs, and it also comes with its own infrastructure and can lead directly back into incarceration, as we'll talk about in just a second. So you can go to the next slide. So thinking about the connections, as we've been talking about throughout this conversation, that Karen was just highlighting around how health and social determinants of health are connected to during incarceration with respect to exposure to disease, violence, severance of social support, other types of destabilization. We also can think about how that persists post-incarceration. So legal disenfranchisement, negative psychological adjustment, unstable housing, which actually is also something that often continues. So a national survey found that 15% of people incarcerated in jail had been homeless the year before incarceration. So that's 11 times more than the estimate for the general population. And oftentimes some of our local work in Wisconsin and qualitative work in our facilities in Eau Claire found that people are often homeless coming out of incarceration too, even though they may not be actually reporting that because of the implications of that. There's also enduring stigma that I think we've seen and understand the negative implications of that across the board, and inadequate supports, barriers to employment, and poor medical care. And I'm not an expert on the systems of reentry, and there are people on this call who are, so I'm not going to try and necessarily be as thorough as Karen just was on all the systems and structures of it, but more just to bring us back again, like I was saying, to the systems and structures in public health that overlap with these goals of the systems that are supporting reentry and how we can more effectively connect dots. So if you go to the next slide. One example of shared goals are around the goals of the Second Chance Act, that if we look at the goals of this act, a lot of them are directly in line with things that we see in our community health needs assessments, for example, stabilize housing, increase employment and job support, provide coordinated and comprehensive mental and physical health services in the community, support the development of safe, healthy relationships, and provide continuum of substance use treatment services in the community. So when we're thinking about what kind of policies we can support and what kind of systems interventions we can support, policies such as this or legislation that advances these different evidence-based structures for supporting reentry are really important for public health to advocate for, be engaged in, and include in some of their strategizing. And if you could go forward to the next slide, please. Just going to run through some examples of systems challenges that that may or may not be familiar to folks in public health. So a while back, we did a health impact assessment on the concept of revocations. So revocations are when people are released, they have to abide by a standard set of supervision rules. And some folks on this call may be really familiar with that. Others might not be. I'm going to drop in actually the rules of supervision for folks who are not, just so you have access to those. And there's been a bit of work to try and reduce these. A lot of them will be adapted or specific to people's circumstances, but there's also the ability to interpret what's included in them. And just want to throw that out there for folks to consider, both with respect to, I guess, I'll skip that. So when we think about the concept of supervision and we think about revocations, what we know about Wisconsin, and based on the health impact assessment that we did, is that about a third of those entering prison each year in Wisconsin are doing so because their supervision was revoked, and they're going back for violating one of these rules of supervision. And so, if we're thinking about what is our collective systemic failure at that point, if that's happening and those goals of reentry are what they are. So it's not necessarily the responsibility of one system or another, but how are we failing folks in that context as systems to try and support, yeah, thank you in the chat, the Second Chance Act information, to try and support people who are coming back. And I think here we also can think about the overlap of the systems with respect to the Department of Corrections and the approach to the rules and the responses to the non-compliance of them that the Department of Corrections has are effective when they're used within evidence-based frameworks. And these frameworks involve wraparound support, things like cognitive behavioral therapy for individuals and their families, navigations through systems of support like transitions to jobs, deliveries of services in community-based settings, and different types of behavioral health supports. So I think this is a place where we have overlapping goals, but underfunded resources and a lack of connection, even though in our local communities, we've been trying to build them through structures like criminal justice coordinating committees. So thinking about where we have opportunities to increase the system's support so that we don't have quotes like what we see here from this parole or probation, this agent, supervising agent that commented during our health impact assessment. There are not a lot of options available to us. So sometimes we just move to using revocations faster because we don't have anything else for us to do. And that's someone who's speaking from the system's perspective that wants to be able to support folks and isn't able to because of our system's failures. You can go to the next slide. So some of the implications of that can be seen in the language of these focus group participants from our health impact assessment. So here's people who are coming out and have been released and are trying to negotiate these rules of supervision, trying to find the programming, and trying to do what we're hoping will happen in the systems of reentry, but that they're living in fear, they're living with toxic stress, they're living within systems that aren't necessarily able to support them effectively, and also they're experiencing the stigma and all of the different conditions that we outlined on the first slide in this section. I'm going to go back to some of those systems of support. Let's give folks a minute to take a look at the language here. And one of the comments here, importantly in the second one in particular, is that when we end up locking folks up even for a day or in any kind of response to violations on supervision when we have these failures to support folks, that can cause people to lose their jobs. It can cause people to lose housing. It can break up family dynamics and family improvements that folks have been engaging in. And that can happen even, as you see in the second one, for an allegation that something has happened. And so thinking collectively how we can decrease the even need for this situation to happen, and then also what other alternatives there are collectively for system support. You can go to the next slide. One of the models that we just are including here, I'm not going to go deeply into it, and we have in the past and we may in the future. So folks in public, this is a public health related model called the sequential intercept model. I'll drop that link in the chat as well. And this is a model that shows the points of intersect with behavioral health and substance use issues along the trajectory, kind of like what we're describing today in these quadrants, and the different intercepts where we can support alternative approaches together. And so just dropping this in here as a resource so we can take a look at it. For the sake of time, I won't get deep into it, but it offers a lot of options for ways that we can collectively try to shift what the experience of people on supervision is like, and how we can support that. You can go to the next slide, please. So in particular, one thing I wanted to highlight that is one of our collaborating organizations, ex-incarcerated people organizing. So I want to highlight this in particular because they have founded in 2014, and we've been a collaborator with them on helping to evaluate their efforts and also on understanding in particular when we say positive and contributing members of communities, what does that mean and how do we support that? So I think one of the ways that EXPO is innovative in that and helping folks rethink the idea of the stigma that comes along with this and what contributing members to communities means is shifting who's leading reentry systems change efforts and who's defining what is important for people who are leaving institutional settings and trying to engage after experiencing a lot of different types of traumas. So EXPO works to end mass incarceration, eliminates all forms of structural discrimination against formerly incarcerated people, and restore formerly incarcerated people to full participation in the lives of our communities. And one of the things that's important about that last piece too is that we often overlook, especially because of legal disenfranchisement, is what does it mean to engage in civic participation and leadership in those communities, and how does that relate to the other pieces of the systems that we're talking about today? We've talked about housing, we've talked about all these different systems, but there's also how you are able to engage in your community to impact the decisions that affect you. And that is intricately and intimately connected to the ideas of important social emotional support and connections for resources around jobs and housing, and having mentors. And some of the lessons that we've learned around EXPO as we've collaborated with them are the importance of relationships with peers built through civic engagement, civic leadership, both in personal and professional, in their personal and professional lives. So again, that social emotional support, connections to resources for jobs and housing, and mentors. Another thing we've learned is the importance of in-reach. So I think some of the literature around reentry talks about the idea of consistent support from systems of reentry, but also I think if we're thinking about that outside of the Department of Community Corrections, Department of Corrections, one of the important things that EXPO has done is build relationships while people are still incarcerated, establishing trusting relationships and pathways to bridge folks with that support that isn't just that system infrastructure, and people on the inside seeing that and having I guess trusted relationships there, that there are folks who are fighting with them and for them and want to see them succeed, regardless of, as I think folks on this call, just to be honest, I think everyone on this call wants to see people succeed, but the relationships there are complicated, and people's personal experiences are things that I think Carl asked us to consider and respect and understand diverse perspectives. And so to see that might be not the experience that someone is having, and to not be trusted, to try and perspective take and understand that, and how that might be operating, and who might be a more trusted relationship or bridge. And to that end, the importance of efforts being led by people with lived experience, and just repeated importance of more immediate trust and a common understanding of experience and empathy, being important for people navigating systems for healing, and for a lot of different, and even for building these types of relationships that we're talking about. Another piece is the importance of training and engaging in communities. So the skills and tools that people were learning included things like group facilitation and training, public speaking, organizational development, lots of these things that, I think folks, especially in public health, we might take for granted too a lot, that these are things that are built into professional experiences in these contexts. So what kind of environments like the ones that EXPO builds are able to support folks in both formal and informal training to do that, and in perspective taking and systems thinking. And I think the last piece too that I just wanted to highlight around the lessons that we've been learning in this space together is the importance of storytelling and speaking to policy and decision makers and being at decision-making tables. So the empowerment and efficacy that, like, in the community that comes from that is directly related to the concepts of success that even are part of the DOC set of standards and goals that they want to support people in reentry processes to experience. So how can we understand what civic leadership looks like and support that as a pathway to reentry? So wanted to just end with that, and then I know I left out huge swaths of the system, but lifting up pieces that we have the direct ability to influence and partner around. I will kick it back over to Stephanie to lead us in the next part.
Thank you, Victoria, and to Karen for working us through the system once people are kind of caught up in that legal justice system, and afterwards, and what healthy reentry can look like, and the work that's ahead of us. So here is where we're going to switch from us talking at you and sharing a lot of information to moving into a small group conversation. So we're going to break you out into small groups of 5. And the 2 discussion questions are here, and they're also posted in the chat. So once you leave the screen, you'll have access to them. But the first is, how are we, or you, currently addressing incarceration as a social determinant of health? So kind of that implies, are you? So you can speak into that. And if you aren't, if you are, how are you? And if you aren't, how might you want to start doing that? I think we shared a lot of different examples, from folding it into existing scopes of work that you're already engaging in, all the way through maybe your curiosity got, kind of peaked as you heard different points of the system, and where might it be important for you to begin to engage. The second is, what do we need to collectively be more effective in addressing incarceration as social determinants of health at each of these points of intersection? So touch on the 2 of these conversations, and then we'll all join back together and have kind of some next steps, which will include us even sharing out a link where we can get some of your responses to your discussion, because it will help inform this criminal justice section here, and how we can bring some more resources and conversations to help meet some of those needs and interest areas. So let's go ahead and break out. And again, the 2 questions are posted in the chat for your reference.
So I just opened all the rooms. Feel free to stay in the main room. If you don't see your invitation into presenters, feel free to decline that invitation.
We hope you had some really great conversations and maybe built some new relationships, got to meet some new people. From here, we have two more pieces of our time here together today, but we do have another session that's set for next month too. So to kind of recenter us and bring it back to kind of people, lived experience, and the impact on people's lives, we're going to turn it over to Carl again to share a little bit more, and then we'll kind of wrap up, share some next steps, and also share how you can access some of the resources and pieces that were shared today. So, Carl?
Right. Yep. So, appreciate you all engaging in the way that you have. Would hope that you all have taken in some insights, particularly get in this room and sit down. Some particular insights about the breakout room and the presentation overall. Wanted to take a few minutes before we close out. Oh, and if you hear that in the background, that is the shelter going, and we are feeding over 100 people like usual today. So amen for that. What I wanted to really speak to you about is buy-in. In closing, I want to take a moment or two to speak to everybody about what that buy-in looks like and what it can look like in relation to my own personal story, as well as the professional work that we all do. I myself am what they would call a directly impacted person. As a formerly incarcerated person myself, I can tell you firsthand what systems are, what they look like, how they function well in some spots and how they don't in others. I spent 16 years in the state prison facility before I released, which was about 6 years ago. And by all accounts, I had done everything right, had connected all the dots, had crossed all the T's, and still, when I was released 6 years ago, nothing worked for me. I couldn't get a job because I was injured, and I had an injury that I had endured while I was in prison, and so I couldn't take a job for which physical, amount of work was needed, and I certainly couldn't get jobs that were willing to work with, technical proficiencies. I couldn't get them to consider it all because I had that socially acceptable stigma on my record of being formerly incarcerated and having a CCAP record to go along with it. Of that category, there were a few people professionally who were willing to sit down with me and talk through what it means to be a part of their facility or their community, their professional community. But then I hit another snag, and that particular snag was that I had been away for too long. I had been incarcerated, like literally, and I've been told many times over, I've been incarcerated for too long. And so because of that, I found myself in a scenario where I couldn't get an opportunity to work whatsoever. And so I was damned if you do, damned if you don't. And unfortunately, I was also not hurt enough to receive disability. And that was because my injury wasn't well documented enough just yet. And so month one, month two, that wasn't the worst thing in the world. I had supports. I had a plan that I had laid out. I had family connected to me. That was fine. But by month 10, I was pulling what little hair I do have left out and thinking to myself, this is how recidivism happens. I didn't qualify for housing programs because I was older and I didn't have kids, and I just didn't meet certain criteria of what homelessness is. I didn't have the opportunity to connect with the one program that DOC had, because at the time it was too narrow of a scope, and that would be Windows to Work. And the ORS program I didn't qualify for, and it wasn't big as it is then now. And all I had was family supports, and that was it, and a little bit of money from transition. Um, and so at month 10, I struggled emotionally to the umpteenth degree to figure out how to get my life back. And the only reason why I stayed the course, I believe, is because I had made commitments to myself and I had made promises to people. And I was part of a community network that was seeing to it that I was okay in spite of having nothing, no job and no money. And that was Expo and that was Wisdom. And I had joined from day one. And so my saving grace was that I was part of a community that understood, and I was part of a community that already had made that transition and had their feet on the ground. Um, I was in the scenario then that after month 10, month 11, I did get a job, but then that job was only given to me because of a formerly incarcerated person offered it to me, and that was at an overnight shelter. And I met that person through the director of Expo, which is Jerome Dillard. Many know Jerome on this call. Jerome introduced me to the guy who, several months later, who was walking with me as best he could. He was busy and professional. But when an opportunity came, he hired me. And once he hired me, the magical, miraculous thing of community happened. And everybody said, this guy's got some real skills in this category. How is it he's not being hired anywhere? And not long after that, I got a job offer with the day shelter. But then after that, I got multiple job offers because it's like an opportunity to get your life back is what people ask for who have been incarcerated. And let me be clear, supervision is incarceration, prison is incarceration. 3/4 of the people who DOC oversees um, are in the parole, probation, supervision category. And so that augmented status of freedom is incarceration. I don't believe that we as a state treat it that way uh, because we take people's street time when they are most times revoked. And that's one of the things we need to look at to prevent recidivism at such a high rate. We need investments in community and we need investments in people in community. And I wanted to be a part of this to both share that as a lesson, um, but also just to as a testimony because in prison I took all the programs that they had, all the programs that were on my A&E, my list of A&E needs to be a part of. I took them, passed, ended up facilitating some of those courses on the peer support side, helping people with their homework through tutoring with the cognitive development and anger management stuff. And by year 12, I had a pretty savvy knowledge of the formulas that go along with cognitive intervention, the formulas that go along with helping a person to do something about that anger state that they're in, that reptilian brain state that we talk about. Um, but even by staff in prison, I was being told that this is not a major step to take. For now, we're just holding you. And so that was a strange and hard thing to do. And so on that note, I will I will pass it back early so that we can go ahead and get up out of here. But I'll put my information in chat for anybody who wants to connect and talk through the rest.
Thank you, Carl, for helping us kind of center the people that are impacted, sharing your story and sharing both the challenge of reentry after incarceration, but also when you have opportunities in connection like you have had through EXPO and through some of the peer support and community support, that we can see that a real impact can be made. So that's the opportunity that's ahead of us. Jess, could you put the slide up? So for all of us here today, we have a couple of next steps. So this is session 1 of 2 virtual sessions. The next one is connecting criminal justice and public health in your own local community. So we're going to highlight some more local ways public health and partners can engage in the system. So bringing it more home now that you saw a broad spectrum of what can happen as prevention, as pre-incarceration, incarceration, and then reentry. What does that all look like to our local communities? What are some examples? What's some champions that are out there doing this work? And hopefully that gives you an idea too, where you can either connect into the work or expand your work. We also, because we are WPHA here for the criminal justice section, our next section meeting is going to be connected into the WPHA annual conference in May on the 24th. That is in person. We will be, so we get a question here. If you signed up for this, we'll be on the email list for the next session. I'm seeing nodding heads. So I believe the answer is yes. Do they need to register for the next session, or are they already registered for both?
Yeah, we'll need you to register again for the April session, but we'll be sending out an email tomorrow with the recording and the link to do that. So yeah, if you signed up for this, you'll definitely get that information.
Excellent. And Joff here is highlighting there's a pre-conference session on partnerships between public health and local jails at the conference as well. So thank you, Karen. The link to the annual conference and information about it is in the chat. We'll also send that out with the email that's going to be going out tomorrow. There will also be a brief evaluation / information, a link for you to share information. Again, take some time to fill it out. It's not going to be too cumbersome, we promise, but it really does help us as a new section figure out where to go next. So your input is really valuable. It's taken seriously, and it really does guide us to help meet you where you are and connect you to the next steps and resources. So we are looking forward to bigger events in the future where we are pulling together community partners, including all the people here and some of the people and organizations that are led by people with lived experience, so we can dive deeper into this and actually build out some of those relationships in person. So thank you, everyone. And if you have any questions, you want to get back to us, you'll have our contact information when we send you the email. So thank you all for being here, and take care.